Good afternoon. My name is John Blazak. I am the Clinical Director of Nuclear Medicine at the Sunshine Coast University Hospital. I want to first thank the conveners for inviting me to speak today and for organising this event. As I'm a dual-trained radiologist and nuclear medicine specialist, so I have a lot of involvement in the oncology MDTs, as I'm sure we all do. And in particular, I have a lot of involvement in the head and neck and multidisciplinary team meeting. There's multiple advantages of attending these meetings, I think, and one of the main ones is that we get a better understanding of how these malignancies are treated and what relevant positive and negative findings on imaging have the greatest impact on patient management and planning. In essence, I've learned what the referring clinicians really want to know. This has helped me tailor my PET-CT reports over the years to highlight these pertinent findings and perhaps disregard some others. And I want to share my insights with a particular focus on head and neck squamous cell cancer, particularly the oral cavity and oropharyngeal SCCs, which are the most common. Obviously, this is directed at those who report these studies, and with the increased use of post-contrast CT with our PET scans, there's a greater onus on PET-CT reporters to add the post-contrast CT information into our reports. And it's quite a complex area in the head and neck, so what I'll try to do with this talk is distill all that information down to a few relevant findings that the referrers want to know that will help them the most, and so we can just hone our reports in that direction. And I know certainly in the southeast corner of Queensland, the use of post-contrast diagnostic CT with the PET scans is becoming more and more common, both publicly and privately. And from a nuclear medicine technologist point of view, obviously the scope of practice is expanding all the time, where there's a greater onus for the technologist to become competent with diagnostic CT, administering contrast, and doing more and more complex studies, which I think is a great thing. I know I started out as a radiographer a long time ago, and the reason I left and went into medicine is because I got frustrated of not knowing the why of what we were doing. I believe conferences such as this encourage nuclear medicine technologists to learn the why of what they're doing, and I think that can only lead to more or improved job satisfaction. This is the Sunshine Coast University Hospital, so it's quite a new and shiny place at the moment. So the larger buildings are the public hospital. You can see it's quite close to the ocean there. On the left is the Sunshine Coast University private hospital that's attached just across the road, and there's also a research institute within it as well. It's a 750 bed hospital, but I think it can increase if they need to. There's room for expansion. It's quite a large campus, and it's also linked to the Griffith University Medical School and a lot of other allied health departments. And obviously it is a coastal hospital near the ocean there, but the catchment area is a huge rural region, and in particular a lot of inland areas. So we see a very wide variety of demographics and pathologies in a large tertiary hospital, but with the added benefit of very little traffic on the way to work. These are a couple of pictures just around the campus or the hospital. The top left there is some of the courtyard, one of the courtyards, some sculptures and landscaping, and on the right is the lecture theatre, or the larger lecture theatre within the research institute, which is used by all departments and the universities there as well. In at the bottom there, in the foreground, is the Research Institute, or Sky Institute they call it, and the background is the public hospital. So not only is it a great place to work, it's even a better place to live on the Sunshine Coast. A bit of shameless advertising here, but Noosa Beach is probably the one most people know about from the interstate, and that's the top left there, Noosa Main Beach. But my personal favourite is Mooloolaba Beach, which is on the bottom right of screen near the Point Cartwright, and there's plenty of seafood that comes in fresh off the trawlers there, so that's showing that at the top right if you're into that. And there's also beautiful rural inland, the hinterland and Glasshouse Mountains. There's plenty of walks, so it's an even better place to live as well as work. All right, so into the more relevant part of the talk. So just some epidemiology of head and neck malignancy first of all. So according to the Bureau of Statistics, there's about 5,000 new cases of head and neck cancer in Australia per year. This is not cutaneous, this is mucosal. It's got a reasonably good survival at 5 years, that's 72% as far as malignancies go. And in this graph here, it's showing that this is the mortality rate, and the orange bar at the top there is the male, and females are at the bottom in grey, and then blue is the average. So it's obviously more common in males, and has a worse outcome. But over the last 40 years, which is since 1982, that's decreased by about half. That's to do with some of it's to do with better techniques with surgery and radiotherapy and improved chemotherapy. But a lot of that is influenced by the rise of HPV-associated squamous cell cancer, which has a much better outcome. So that's influencing those curves a bit. The most common sites are in the oral cavity and the oropharynx for the primary malignancy, which is what I'm going to focus on today. And importantly, if there is a nodal metastatic disease present, the 5-year survival drops quite significantly by about 50%. So that's an important and relevant finding. So what I'm going to focus on today, like I alluded to, is how we refine the reports, particularly with a focus on CT, with what characteristics of the primary malignancy and what characteristics of the nodes should we include and have the most impact with referrers that they want to know. So first of all, just starting with the T staging, which is assessing the primary malignancy and the oral cavity. So oral cavity is the tongue, the floor of mouth, retromolar trigone. The base of tongue, which is at the back of the tongue down on the lingual tissue, is actually considered the oropharynx, so it's separate. So for these oral cavity lesions, there's a lot of information here, but the relevant findings or relevant measurements that come out of this are the 2 and 4 centimeter cutoff. So that has a large influence on the T staging, and that is the maximum length of the lesion. So it's not just in the axial plane, there's in all planes. They want to know the maximum length. So you can give multiple planes if you like, but the most important measurement is the maximum length. And this is if you can see it clearly enough on the CT with the PET. Often it's quite obscure depending on how much dental artifact they have. Another important measurement is the depth of invasions. That's essentially the thickness of the lesion when it's on the tongue. And the cutoff measurements or threshold measurements for changing the staging level are the 5 and 10 millimeters. So the reason I mention these numbers is if you're measuring a lesion, and you can measure it as accurately as you can, particularly if it's close to those threshold measurements. You don't want to be too cavalier with the calipers there because, a few millimeters over and under has a big difference in the T staging, and occasionally it can have an influence on their management too. And finally, the other relevant feature to mention in your reports is invasion of adjacent structures. And we can use all of the information we have with the FDG uptake, with the post-contrast CT and an MR or whatever we've got available to assess for that. And in the oral cavity, the place you particularly want to look are the extrinsic tongue muscles, so in the deep part of the tongue there, and also the mandible, to mention a few, sometimes the submandibular glands as well. This is a post-contrast CT that's been done as part of a staging with the PET scan. In the pointer works in the left posterolateral tongue here is this enhancing primary malignancy, and the 12 millimeter calipers are measuring the depth. So that's the depth of invasion from the mucosal surface down to the deep margin, and you can see it's 12 millimeters. So that's over the measurement of 10 millimeters cutoff. So this makes this at least a T3 primary malignancy on the tongue. Bearing in mind we haven't measured it and looked for invasion of adjacent structures yet, but at least on this slice, that's the most important measurement. This is a post-contrast, different patient with a post-contrast CT in the coronal plane, so looking from front to back. Also done with a PET staging PET scan, and the primary malignancy is centered on the left tongue here. So you see this enhancement. There is quite a bit of atrophy of this left tongue. You can see it drops right down, and that's in this particular case involvement of the hypoglossal nerve and denervation, that automatically makes it a T4 lesion. But that's not what this case is about. The teaching point. What I want to show you in this is the sort of anatomy. So this black vertically orientated line is the lingual raphe in the midline of the tongue, and on either side of that raphe is the vertically orientated genioglossus muscle. So it's just this grey strip here, and the other one, which is obscured by the red arrow, is the left genioglossus. And you can see the primary malignancy extends deep down, and just at its deep margin where the red arrow is indicating, it's contacting that genioglossus muscle. So this is suspicious for extrinsic, which is a genioglossus is an extrinsic muscle. This is suspicious for extrinsic muscle involvement and would make it a T4 primary malignancy. This is the same patient but with the MRI. So this sometimes gives you a little bit more information about invasion of local structures on MRI if it's available. Obviously not always done with a PET, but it sometimes is presented to you at an MDT, so it's good to know something about it. In this particular case, on the right, you've just got that midline black line again, so that's the raphe again, so we can see that clearly. And then outlined in blue on the right is the normal right genioglossus muscle, and then the enhancing tumour, which is roughly outlined in the red on the left tongue. And that's invading deep down, and you can see that is the normal signal of the genioglossus on the right, and the left is being replaced or invaded by the tumour with that enhancement. So this is again a T4 primary malignancy in the oral cavity. So moving on to the oropharynx, so this includes base of tongue, like I mentioned, and also tonsil primary malignancies. Thankfully, the measurements are similar. So the cutoff measurements, once again, in the longest plane, the longest dimension, is 2 centimetres and 4 centimetres. So if we've got a visible lesion on our CT or MRI or whatever, and you can measure it, you know, the cutoffs of 2 and 4 are important. The additional information for oropharynx is, in particular, if it's a base of tongue lesion, does it involve the lingual surface of the epiglottis, which I'll show you an example of. And T4, just like in the oral cavity, does the lesion involve the adjacent structures? So, for example, if it's a base of tongue lesion, does it extend anteriorly and to involve the extrinsic muscles of the tongue? If it's a tonsil primary malignancy, does it extend laterally to involve the pterygoid muscles or superiorly to involve this skull base, for example? This post-contrast CT in the sagittal plane is highlighting a base of tongue malignancy. So showing along here, this is a normal, thin base of tongue, or posterior tongue, and then the more inferior base of tongue here becomes thickened, irregular, and enhancing. That is the primary malignancy in the midline base of tongue there. You can see the enhancement and irregularity goes down and then wraps up along this surface. So this structure here, this curved structure, is the epiglottis, and this anterior part of the epiglottis, or anterior surface, is actually the lingual surface, being closer to the tongue, and that involvement of tumour extending along that lingual surface makes this a T3 lesion based on T staging. So that's an important radiological finding to comment on. You can see a nice normal dorsal surface of the epiglottis there, thin and not irregular, and nice and smooth. This same patient just highlights, this is just outlining that where the tumour is on the red, so you can see a bit more clearly along and extending on that lingual surface, and the smooth remainder of the epiglottis dorsally. Just because I probably should include a PET image somewhere in the talk, this is an important finding to comment on in our reports. Now, it's not included in T staging, but the referrers always want to know, does the lesion, is it well lateralized? As in, is it a long way away from midline, or does it go up to or across midline? And you can see in this case here on the left there's a asymmetrically increased FDG uptake in the right tonsil, which is well lateralized. It's a long way away from midline, does not extend up to midline. In contrast, the image on the right, whereas the lesion centered in the midline at the base of tongue and extending to the right and left of midline. They all get treated differently and offered different treatment pathways. This is obviously an extreme case where it's obviously extending across midline, but even if it extends up to and close to midline, they'll want to know that particularly. All right, so staging of lymph nodes. Fortunately, lymph nodes are the same staging criteria. Doesn't matter where the primary malignancy has come from. So that's helpful. The cutoff measurements, they were 2 and 4 centimetres for the primary malignancies. For lymph nodes, it's 3 and 6 centimetres, where there's a jump in the nodal staging. And really importantly, just like in the primary malignancies, this is the maximum length or the maximum diameter of the lymph node that this number is pertaining to. So if we've decided that a lymph node is involved, and we decide that based on its FDG uptake, whether it's necrotic, has other features that are suspicious, suggest that it's involved, the referral will then will know, okay, tick, it's involved, and how big is it? And that's, we only really want one measurement. We can measure in all three planes if we like, but they just want to know about the longest. Is it more or less than 3 or more or less than 6 centimeters? In addition to that, is there just one node involved or is there more than one? And that's important to comment on. Even if it's just sitting next to the other node, it's important to say there's more than one because that upstages it to N2. And then are there involved nodes contralateral or on the opposite side of the primary malignancy, which upstages it to N2C? The final feature of lymph nodes that's really important to talk about, and is more of a CT or MRI finding or radiological finding, is extranodal extension or extracapsular spread. Same thing. I'll probably interchange talking about them as I do. But that automatically makes it N3 disease, and I'll show you some examples of that. Before I do that, I just want to flag a few things about neck levels. A little bit of a bugbear of mine, but I think when we're talking about, particularly talking about head and neck malignancy, lymphoma and other diseases, it's not particularly as important because it has less of a surgical focus. But for head and neck cancer surgeons, the head and neck surgeons want as much information as possible, and the best way to do that consistently between reporters and referrers is to talk in neck levels. Some reports you see around talk about, the submandibular node or the jugulo-digastric node or a supraclavicular node, but that's not really a standardized way of talking about it. It can be interpreted differently, whereas these neck levels are all very much strict criteria about where they're located. So it should be consistent between everyone. We're all talking the same language. The only thing I want to flag in this is the difference between 2A and 2B, which is some confusion out there. So 2A and 2B up here at the top is one of the most common sites of nodal metastatic disease from mucosal or even cutaneous disease in the neck, in the head and neck. And the difference between 2A and 2B is this dotted line here, and that is the posterior margin of the internal jugular vein. So anything posterior to the posterior margin of the internal jugular vein here is 2B. Anything anterior to the posterior margin of the internal jugular vein is 2A. Except for when you see this situation here. So in this case, this is a post-contrast CT again for a staging scan, and there's multiple right neck nodes that are enlarged and were FDG on the PET scan. You can see that sandwiched between the two is this internal jugular vein, and it's more clearly seen on this sagittal plane where there's a cluster of partially necrotic nodes, and then posterior to the internal jugular vein is this node which is contacting the internal jugular vein. Now, there is no fat plane. What I mean by that, there's none of this black dark fat separating the lymph node and the internal jugular vein in any plane. It's right up against it. That makes this a 2A lymph node. Even this node posteriorly here is still 2A because there is no fat plane separating it from the internal jugular vein, which is a really important distinction. This image is just outlining the margins of the nodes and demonstrating that there is no intervening plane between this posterior node in the internal jugular and the internal jugular vein, so it's 2A. This is in contrast to this study, so this is also a right-sided involved node. You see it's very large necrotic node here. And anterior to it is the internal jugular vein. Similarly, on the sagittal plane, this is the involved lymph node, and this line here is the internal jugular vein, and there's a nice large fat plane separating the two. So that's indicated by this blue line here separating it. So there is a separate fat plane there. So this means this is a genuine level 2B lymph node. So that's just an important distinction that I want to make. This is the other feature about why it's important to measure in 3 planes or find the longest dimension. So there's an involved right level 2A node here, which has got calipers on it. It's partially necrotic. It's very enlarged, so it's definitely metastatic. But the axial dimensions are 20 by 28. So that if you just left it at that is an N1 because it's less than 3 centimeters in maximum length. When you measure it in all planes correctly, it's actually 3.5 centimeters at its maximum length. And that's common for these because nodes in the neck are constricted by, or restricted, beg your pardon, by a lot of normal anatomical structures in the axial plane. So they tend to grow up and down in the craniocaudal length. So they're often longest in that dimension. So really important that we measure the longest dimension. So that means this is actually N2 staging for this particular cancer, providing there's no other disease. This is an MRI, obviously moving a little bit away from our usual spectrum, but this is MRI T1 non-contrast coronal image showing this involved right neck node. You can see it looks like a little smooth egg in the neck, and this right signal indicated by the red arrows around it is the normal fat plane. So on T1 sequence of MRI, fat is bright. So this is showing a fat plane around the node. It's smooth. You can draw a sharp line around it. On the post-contrast MRI, it has a nice, it looks like an Easter egg. It's got this, just incidentally, but it's got this the enhancing thin wall that's smooth, and the surrounding tissues all look normal without any abnormal enhancement there. And you draw a nice sharp circular rim around it. So these are all features of a node without extranodal extension. This is in contrast to a different patient with a post-contrast CT neck with the PET, and there's an involved large node here, very different in morphology. This one has very shaggy, irregular, hazy margins to it, a bit spiculated. The fat surrounding the node is stranded, and the muscles here at the deep margin and superficial margin are almost indistinguishable from this node. So that implies that there is extranodal extension or extracapsular spread into those muscles. So that will upstage the nodal staging. We usually use that in combination with the clinical findings. So if the surgeon was to palpate that neck and that left side of the neck, they'd feel that it would feel quite fixed, and it would be stuck with the underlying structures and be quite hard and nodular. Lymph nodes, like the first one I showed you that look like an Easter egg, they're more smooth to the touch. They move separately to the structures underneath them. So we sort of combine the clinical findings of what it feels like and the radiological findings of those irregular hazy margins and loss of fat planes around it to imply that there is extranodal extension, which is important before they go and decide what to do for management. We draw a line around this particular involved one to see it's quite irregular, sharp margins to it. Just highlighting that again, this is the same patient in the sagittal plane, highlighting those sharp irregular margins, and it's indistinguishable from the sternocleidomastoid muscle that is involving anteriorly there. So why does all this matter? This is where it comes into play. So all this nuance and semantics that we talk about. Well, the difference between staging something as T1 versus T2 or N1 versus N2, etc., is really important because it will dictate what the management plan is for this patient. If we give them the wrong management plan, then they may have a poor outcome. So treatment algorithms are not particularly standardized. There is general and accepted pathways of treatment, but it's not the same everywhere. But these are a few examples of what treatment might be offered in the red here based on the scenario of staging in the blue. Starting with oral cavity. So for tongue malignancies, for example, the mainstay of treatment is still surgical, and that is because the mandible's in the way when you give radiotherapy, and so you have to basically irradiate the mandible. It undergoes radionecrosis and it crumbles away. So we still offer surgery, or surgery is still offered for primary malignancies in the oral cavity as a mainstay of treatment, if possible. If it's quite a small tongue malignancy or oral cavity malignancy, T1 with no FDG avid or involved nodes on CT, like the first scenario, they still often offer a neck dissection on the same side just in case we've missed microscopic disease, or for some patients they might just observe. If the primary malignancy is a little bit bigger or is extending deeper down into the tongue, they will offer, quite strongly encourage, an ipsilateral neck dissection, even if we don't see any disease on FDG PET and CT, because this person has a high risk of microscopic disease. If it extends up to midline, it's a higher grade T3 or T4, then they will also strongly offer a contralateral neck dissection because this patient has a higher risk of spread contralaterally to lymph nodes. Or like the bottom scenario there, they might offer contralateral neck radiotherapy, but it'll depend on where you are in the patient. Important one is the N2 and N3. If there's nodal disease at stages N2 and N3, even after the surgery and they've resected those nodes, they will then give adjuvant radiotherapy. So the scenario I showed you previous slide where there was a lymph node where we measured in the axial dimensions, it was N1, but when you measured it in the longest dimension, craniocortial, it was then N2 disease because it was over 3 centimeters. That would make a difference to this patient because in the first scenario, they wouldn't have got radiotherapy necessarily. In the second, they would have been offered radiotherapy. So it does make a difference. For the oropharynx, there's just a couple of extra scenarios here and more highlighting if it's well lateralized, be it base of tongue or tonsil. They'll still offer an ipsilateral neck dissection most of the time, but if it extends up towards midline or along the posterior pharyngeal wall in the tonsils, then they will offer a bilateral neck dissection or bilateral neck radiotherapy. So that's why it's important to comment on that. And if there's any nodal metastatic disease with obvious extracapsular spread, both clinically and radiologically, based on the features that I've shown you, involvement of adjacent structures like the carotid sheath or nerves, then they won't want to cut that because they're cutting into that. It's stuck down to all the normal structures. We've got to resect a lot of normal tissue. There's a lot of morbidity. So for those patients, most commonly they'll offer chemoradiotherapy only. So I just wanted to lastly just make a quick comment about not so much report structure, but report content. I don't want to sort of give to my comments on T and M formats of reports versus body system reports. What I basically want to highlight is when we're talking about primary head and neck malignancies and the nodal status, there's certain features in a report that we should include. You can write as much as you like, but this is what they're going to want to know. First of all, what's the maximum length of the primary lesion, even if it's craniocaudal? You can list all dimensions, but they don't necessarily read them. They just want to know the maximum, with relevant lengths of 2 and 4 centimeters for cutoff to upstage the T staging. If it's in the oral cavity, how deep is it invading? How thick is it? Will influence the T staging. Is it involving adjacent structures like I've highlighted? Does it involve the mandible if it's in the oral cavity, or extrinsic tongue muscles? Does it extend along the lingual surface of the epiglottis or base of tongue primary malignancies like I showed you in the example? If it's a tonsil, does it extend laterally to involve pterygoid muscles? Once again, this is probably best appreciated on post-contrast CT or MRI. The former we're doing more commonly with PET, so there's an expectation we should be able to look for these findings. In MRI, sometimes you are thrown under the bus a bit depending on who's in the room and they want you to comment on it. So it's good to have an idea of what to look for. And then finally, for a T staging, is the lesion well lateralized or does it extend up to and across the midline is something that's important to comment on. And quickly, just for nodal staging, first of all, it's the same end staging for the oral cavity, oropharynx, any larynx, anywhere in the head and neck. The end staging is the same, which is convenient. Remember, it's the maximum length, even if that's craniocaudal, which it often is. The relevant cutoff lengths measurements are 3 and 6 centimeters. So if you're measuring close to those, be very accurate because it will change the end staging. Look for a second involved node because, as I mentioned, that does upstage it as well. And then assess for those features that I've described of extranodal extension or extracapsular spread on CT or MRI, because that will also influence whether the patient undergoes surgery or just chemoradiotherapy or a mixture of the two. So there's my thoughts on what we should be, I guess, commenting on, how we refine our reports to make them most relevant to bridge the gap between head and neck or imaging head and neck malignancy and our referring clinicians by just focusing on a few important primary malignancy and nodal staging features in our reports, which have been drawn from my experiences in MDTs mostly. And for the technologists listening, I hope this presentation has shed some light on the why of what you do and the important role we all have in getting the best outcome for these patients. These are my references, and thank you very much.